Greetings. My name is Gray Andrus, and I was asked in late February, early March to step in as interim clinical director by Courtney and agreed to do so. And she's asked me to join you all for this board meeting and introduce myself and kind of share with you some of the things we've accomplished in the last 60 days and kind of the direction the clinical team is headed. And so I'd like to take a moment to share a few of those things with you. So again, my name's Gray Andrus. Full-time, I'm an assistant professor of social work at Missouri Western Missouri University in St. Joe, Missouri. Um, and that's something that I love to do. I'm also an adjunct at the University of Kansas in the School of Social Work. So I began working with children and families in 1986. My work has primarily been working with kids who are in and out of the child welfare system, helping them get reunified with their parents, helping parents and families heal, sometimes helping kids get adopted to a new home or permanent family. And that's been the bulk line of my work. I have a bachelor's degree in community health education and a master's degree in social work from Kansas. And then I have my doctorate in social work, DSW, from USC in California. So Courtney challenged me to work with the clinical department and to assess what's going on and to assess them. And so I readily agreed to do so. And I have to share, I'm having a blast doing this. There are so many really talented clinicians on the clinical team right now. We're a team of 8, and we'll be growing to a 9th person the 1st of June. And everybody is just talented, really hungry for information and hungry to really become, a team and a department and an agency that embraces excellence. I thought I'd share with you some thoughts I had about excellence and moving towards excellence. These are some data that's on the front page of the Newhouse website. I'm sure all of you are very familiar with it. The numbers are impressive from 2020, 23,000 program sessions for adults and children, 18,000 nights provided. I mean, these are some great numbers. But as I was telling Courtney, it doesn't tell the story of excellence. What's missing is outcomes. How many clients were admitted to Newhouse that finished a program, that finished the program? We have to define what program is, and clearly that's an issue we're working on. But within those outcomes, how many of those clients felt they were heard, listened to, validated? How many of those clients thought our method was spot on? It really met them. How many of those clients thought we helped them work on what they wanted to work on? While these numbers are impressive, they're missing outcomes. We're not truly getting a picture of Newhouse and its quest for excellence. So in the past 60 days, I have, of course, met with the entire clinical team, had a chance to get to know them. Currently, I'm meeting with them individually for supervision, and then we meet as a group on Wednesdays from 11 to 12 for clinical. And that meeting was decided by them to be a meeting to develop their professional growth, not a meeting to discuss clients. I have had a chance to meet with the lead advocates, and we had a very productive meeting. It's clear to me that they are the heart and the soul of the agency, but as a heart, they're functioning at about 55%. And they are the youngest, least trained component of this Newhouse team, and we're going to make some changes to that. They're hungry for some information and some training, and I'm excited about that. I've had a chance to meet with the case managers. And we're growing case management. We'll have 2 therapeutic case managers as well as 2 standard case managers. And one of the things I've also noticed with them is that they don't have a framework or reference that they work from. So last 60 days have been pretty busy getting to know staff. I've also started by creating some collaborations. Courtney had began a relationship with James Gill at Truman, and I kind of taken that to the next step. The goal of that collaborative relationship is when we have clients that would benefit from psychiatric support, that Truman would offer that to us, maybe virtual, maybe 2 or 3 hours a week. They would give us a slot for us to use with our clients. And April 21st, I brought in Jasmine Foster. She is the lead social worker in the Truman Behavioral Health in the emergency room, and she trained staff on how to write effective affidavits. On April 28th, I brought in Lindsay from the Kansas City, Missouri Police Department. She's an embedded social worker there, and she shared with staff how to better use CIT officers and how we can strengthen our relationship with the police department. Also, I've connected our recovery specialist, Miss Bishop, with Patrick Pruitt. He is substance abuse supervisor, because for us to offer substance abuse, we need to do so with credentialing and qualifications. And so Chenoa Bishop is moving in that direction. So some collaborations to be scheduled. I'm bringing in Zatina Rodriguez. She is the lead advocate for the Children's Advocacy Center, where hotline calls are evaluated and kids are interviewed. She's going to come in and share with staff what's it like for a child and a family to go through the interview process. Also, I do plan on scheduling a field trip to the KCATC Assessment Center with Michelle, so that staff can see what that 23-hour assessment center looks like. Each one of these is an opportunity to build and collaborate with our partners in the community. Also, I'm really excited. One of our clinicians, Andrea, had shared with me a professional goal is to develop her leadership skills. An outstanding way to do this is for her to oversee internships from social work schools. So she's connected with University of Kansas, and I got her connected with UMKC, and it looks like, cross our fingers, we will have a couple graduate students doing internships next year. It's a great way to collaborate with these two agencies, University of Kansas and University of Missouri Kansas City, as well as an opportunity for us to do research, for our staff to participate in research and maybe be published. It's an important relationship. We also will be having a student from Missouri Western that I helped facilitate that connection between Andrea and the field practicum director there as well. Over the past 60 days, I've trained all the clinical staff in feedback-informed treatment, which is an evidence-based model for outcomes to be client-driven. And we've brought in Dr. Bill Geis for suicide awareness. He spent 2 hours. We did videotape it. We will make the video available to all Newhouse staff. And it won't be, hey, you should check this out. It's going to be, hey, we need this training. He's going to be back in the next 60 days for another 2 hours. We will not tape that, because that's going to be looking at several cases and case specific. That's going to be more of a consultation as follow-up to his training. So one of our other goals is to become client-centered within a trauma-informed framework. So one of the things we need to do is look at every policy and practice that says, we don't trust you. We are the expert. We don't trust you. It tells the client that they are, in essence, the problem. It is very much an us and a them component. We're here and you're here. In social services, there are 3 values that are woven into practice and woven into the code of ethics that we need to not just talk the talk, but walk the walk. And number 1, meet clients at their level of functioning, which means we can't be here and they're here. We need to be here with them. We need to value the client's self-determination and not work harder on them on their issues. So for instance, right now we do screenings. That feels a little bit like fingernails down a chalkboard to me. We screen for COVID, we screen for sexually transmitted diseases, and that's not what we're doing here at Newhouse. We need to build rapport and form alliances with clients and take what's called a social history. So we need to look at all this problem-focused language, problem-focused policies and practices, and be willing to ask ourselves, what would it take tomorrow if we woke up and we had removed all of these? Also, right now, I have a team of 4 clinicians working on our assessment process. It is to me like a corn maze, which is great at Halloween, but you don't want it the rest of the year. There's some redundancies in this assessment process. And again, we're screening people, and we need to change that focus. So here are some examples of some language that you can hear around Newhouse that we need to move away from. Clients are just manipulative. Well, those clients are in denial and they're unengageable. What's wrong with them? Clearly they're crazy or they're just a bad person. They're not ready for treatment. They're not ready for housing. It's a privilege. The language is blaming and it is problem focused, and we need to move towards being solution focused. Here's an example of some paperwork. This was a substance abuse treatment consent. If you continue using drugs, this may result in termination from the recovery program. If termination occurs, I understand that Newhouse will provide other resources for me to transition to another outpatient recovery program. First off, in the world of recovery, every client is going to have a setback, and that's okay. It's okay to fail in treatment, and we want clients to fail and to understand failure, to understand that this recovery situation they're in and using substances is more about escaping the pain. And it's okay to fail. So the new languages you can see below highlighted in green, continued use of substances may result in reevaluation of my program needs. This will be discussed in individual counseling, and any referrals or changes to programming will be done with the client's consent and participation. Can you see the shift in the culture and the language? In green is the shift that we're needing to make to be client-centered, to be trauma-informed, and to be strength-driven. So in the next 60 days, I'll be training all the case managers in solution-focused case management to give them a foundation, a framework to build on. It is a best practice initiative. I'm going to start training lead advocates in some therapeutic crisis intervention. Again, they're the heart and the soul, but if we disempower them, then our heart is functioning at 55%, and that's not good. We're going to have Dr. Geis back for Suicide Awareness Part 2. We're going to do hotline training. We're going to look at documentation. We're going to look at treatment plans, but we've got to get this assessment piece in the corn maze figured out first. Also, we'll be doing trauma-informed care onboarding for new hires, for volunteers. So it's just really exciting the direction that we are headed. So let me take a moment to stop sharing. Again, I'm sorry for not being at the board meeting this time. In the future, I'd love to be there if you'd like to meet me. I would very much like to meet you. Thank you for your commitment. And most of all, please thank Courtney. Her vision is spot on. She is a social worker at heart. So she gets a little M and a little S and a little W. I'm just so excited to be there. And I'm really excited about this continued progress we're making. You can look at the analogy. It was a giant ship missing a rudder, and now we've got a rudder, and this ship is turning, and it's turning towards a bright future. We are going to be an agency that excels to excellence, and I'm pretty excited about that. Thank you so much. Look forward to meeting you all in person. Take care now.